then asked for some direct histological referrals from 2008. So what did those sort of things do? I think the biggest thing, you can see that in terms of GP referrals, so those are the GPs, and the red bits are the cancer referrals. So firstly, A&E awareness increased quite a lot since we started. The screening program sort of varies, but the other big change you can see is in the other, because lots of people would then go and see a GP, go and see someone else, go and see someone else. By the time the fifth consultant had seen them, then the diagnosis was made. So we were looking to reduce that large, almost 40% of sources of other cases to a much more manageable 20%. And if we do it particularly by Hackney GPs, for the GPs that are actually here, so you can see, again, that works out much better. Interestingly, there have been fewer referrals to A&E from GPs because GPs are beginning to make the diagnosis for even extrapulmonary disease. Cure rates and sputum. You can tell almost how a service is working by whether, when they do the LTBR, they've actually got a sputum result or they say that it's pending. And what was most noticeable is that a couple with a reasonable cure rate, so that's the City and Hackney and Tower Hamlets boroughs, they seemed to send sputum early, and that was probably from their GP involvement compared to the boroughs where the cure rate was actually worse. So standardised treatment, here we use the Orange Book from the International Union, which means that you can actually check whether you have every dose. And that means in terms of DOT, they can just put a cross in it, or the patient can take it home, or their mother, or a friend. Anybody can make sure that they actually take their treatment. And you can see that, so that was the initial phase, and this is the follow-up phase. And what we've noticed that as we managed to sort out TB, suddenly we had people with lots and lots of risk factors for non-adherence. So these include things like alcohol problems, drug taking, imprisonment, previous TB, homelessness on the street. So, and that's what you should expect as a TB service improves, because you can easily deal with all the lawyers that come to you with TB, but it's much more difficult to deal with those who don't want to come to hospital and don't want to continue their treatment. And so one of the most important things, which is not generally available in London, is directly observed therapy, which just means supervised swallowing. You stand over them and watch them take it. And you can see that as we introduce that, we've sort of come to a level of around about 40% of DOT for all our TB in order to have cure rates which are sort of 95, 96%. And I think you can see that unless you have at least 20% DOT, well, 25%, your cure rate is going to be less than 90%. And the thing about DOT, it can be given anywhere, homes, nurseries, we give a lot of pharmacy DOT for the, in fact, it's a requirement for the opiate, the methadone program, but really anyway, and I've even put in the off license because you can't necessarily cure alcoholism, but at least if you can cure their TB and start them on the road to, social support, then that may be effective. And if we look at mental health, again, you can see that there's this enormous problem that we have locally in terms of drugs and alcohol and psychiatric referrals. This is a particularly bad year for that. But you can see how much it's changed over the period of time, that a lot more of our TB patients have these things. And Sue's going to talk a bit about homelessness, but this is just to show how different it was in 1997 to what it is now. In terms of drug supply, well, this is just a sort of characteristic year to show how for ages we didn't have BCG or PPD, and last Thursday in Copenhagen while I was there, the minister was interviewed saying that he's not going to give any more BCG or PPD to anywhere in Europe or sub-Saharan Africa. So the main source is gone, and I think the availability from Canada and from Japan are going to be difficult to scale up in the short times necessary. And then in terms of TB drug supply, these were characteristics that often you don't get streptomycin. We had a problem with pyrazinamide, and now we import a drug that's actually not recognized from Czechoslovakia. And streptomycin actually won't be available from next year, largely, I think, because of this misconception that there's a lot of streptomycin resistance around, but in fact there isn't. We only have 1 or 2 streptomycin cases a year, resistant cases a year. It's not routinely tested for, but if people can't take rifampicin or the short course is shorter than the 18 or 20 months, MDR-TB needs streptomycin. So an MDR-TB is going to be a problem. You can see that it's not quite an invasion from Russia, but you can see the colours are definitely getting redder as they border the previous Russian Federation. And in fact, only Portugal has a really high incidence. So, and again, most of ours, this is taken from the HPA, most of our TB comes from Eastern Europe, MDR-TB. And in terms of the second-line drugs, these are things that you don't actually have to remember. I would look them up and ask advice on the BTS line every time you need to prescribe them or talk to somebody about what do I do with this person with MDR-TB. But the ones in red, these are the ones that just over the last 6 months we've had difficulty obtaining. So you can see that actually maintaining a drug supply is really much more complicated than you might have thought. And then you want to check what you've done. So that's cohort review. And that's something that we started here at the Homerton with Jose Figueroa, who was our DPH at the time. And we included all pulmonary and all difficult cases. And that led to an improved evidence of cure. People started sending off sputum at 5 months to say they were cured. And this practice spread, so now it's in North Central and North East London, but at the moment the actual review of cases isn't the type that you want to look at. You want to look at the ones that are going to be infectious or the ones that are going to cause you problems, and what did you do? So, and you can see that at the moment we had this cohort review, so that's 2007, suddenly our proof of cure gradually improves. So it's only a matter of audit and reflection. And similarly, you mentioned the cure rate. So now, although I've put this and you think, oh, how terrible Newham is, I think these are the conclusions. You know, they need to have the same level of investment throughout London. There should be no sort of boroughs that are unique. The target of 1 in 40 has never been achieved in Newham. And the medical input, which is meant to be 4 hours per 25 patients, you know, well, if you've got 350 cases a year, you know, you can work out how many 25s there are. You know, that's more than one full-time consultant, and we had Jeff Pack there as the only one with 2 sessions. And it relates to deprivation. So to me, it's clear that if we're going to sort out the problem, we need those high-incidence boroughs and actually do something a bit extra and do it quickly before the problem becomes too great. Good. Anyway, I must thank all my colleagues, all my TB nurses, some of whom are here, because I think without that sort of teamwork and linking with the community, TB care doesn't actually improve. Good.